Today our session is about development of the gastrointestinal tract. So this is the learning objective of this session. And these are the references for this session and the assignment reading. Chapter 14 in the Langsman Medical Embryology and Chapter 11 in the Kithmore Developing Human. Just note that this presentation was prepared for lecturing purposes, and the only official references for this session is the assigned references book as mentioned in the blog. This is the lecture outline. We'll start with the brief introduction, and then we'll go through the development of the gastrointestinal part that will be divided into 3 parts: foregut, midgut, and hindgut. And then we'll go to the development of the associated digestive organs. First, introduction. As you remember, phases of the embryonic development, we have 2 phases, embryonic period and the fetal period. Embryonic period from week 1 to week 8, and it's subdivided into 2 sub-periods. First 2 weeks we call it the blastocytes period, and this is involve cell proliferation and formation of the zygotes, and then morula, and then the blastocytes. And then at the end of the 3rd week, second week, week 3 to 8, we call it the main embryonic period. It's active period, involves gastrulation, folding of the embryo, and formation of the organ system, somatogenesis, cartogenesis, neurogenesis, and plecodes. After that, the fetal period. Just to remind you that most of the congenital defects occur in the main embryonic period from week 3 to 8. So here the early development of the embryo at the beginning. At the end of the 2nd week, we will have bilaminar germ disc consists of epiblast and hypoblast, and then the gastrulation process that will be start in week 3 around day 15. The trigeminal cells it will be formed, consist of ectoderm, mesoderm, and endoderm, and this gives rise to the paraaxial, intermediate, and lateral mesoderm. The lateral mesoderm it will be subdivided also into 2 groups: the somatic and the splanchnic mesoderm. And then we have the notochord formation. By day 18, it's induced the ectoderm to form the neuroplate that gives the neural tube. The neural tube it will be formed the central nervous system consisting of a brain and the spinal cord, and then the neurocrest cells it will form the peripheral nervous system. So development of the digestive system, it will be beginning during the 4th week of development, and this is include 3 foldings that help to forming the digestive tracts. So we have the cephalic folding. It will give rise to the foregut, the upper part of the gastrointestinal tract, and the lateral folding it will help form the midguts that remain continuous with the yolk sac, and we have the caudal folding forms the hindgut. So development of the digestive system, the buccopharyngeal and the clavicomembrane form the beginning and the end of the digestive system. So the digestive system and its associated organs are derived from the endoderm, the ectoderm, and the mesoderm. So the endoderm cells what will form the epithelium that lines the digestive system tubes, and the parenchyma cells that give rise to the associated digestive organs. So all the epithelium that we will discuss tomorrow in the the gastrointestinal tract would be formed by the endoderm. Okay, most of the gastrointestinal tract it will be formed by the endoderm cells. The ectoderm cells it will form the epithelium that lines the oral cavity, the beginning of the gastrointestinal tract, and the end of the gastrointestinal tract, which is the distal portion of the anal canal. So all the gastrointestinal tract will be formed by the epithelium, it will be formed by the endodermal cells, except the beginning and the distal end of the gastrointestinal tract, which will be formed by the ectoderm cells. Splanchnic mesoderm, if you remember, the splanchnic mesoderm or the visceral mesoderm, we call it again also, it infests the developing tube and forms or give rise to the connective tissue, smooth muscles wall, and associated blood vessels and surrounding endodermal cells. And also we have the dorsal and ventral mesentery, which will be formed also by the splanchnic mesoderm and help to suspend the gastrointestinal tract in the abdominal cavity. So during the 5th week of gestation, the primitive gut tube will undergo epithelial proliferation, and this is lead to obliterating or closing the gut tube completely. However, in week 8 to 10, the recanalization process it will start, apoptosis process, and this lead to restore the gut lumen. However, sometimes the recanalization process it will fail completely, and this lead to formation the atresia, completely closing of the gut tube. And sometimes the recanalization occurs incompletely, resulting in the narrowing the gut tube, and this is causes stenosis. So then the primitive gut tube is divided into 3 regions according to the blood supply. So we divide it into foregut, the upper part, the midgut, the middle part, and the hindgut. So we have this part here, foregut, midgut, and the hindgut. The foregut extend from the buccopharyngeal membrane to the opening of the common bile duct, or the upper half of the duodenum. The upper half of the duodenum. This part, the foregut, supplied by the aortic arches and branches from the descending thoracic aorta for the esophagus part, or the part above the diaphragm, and by the celiac artery for the part below the diaphragm. The midgut extend from the lower half of the duodenum, or from the common bile duct, to the proximal 2/3 of transverse colon. And this is part supplied by the superior mesenteric artery. Hindgut extend from the distal 1/3 of transverse colon to the upper anal canal, and is supplied by the inferior mesenteric artery. So according to these blood supply, the digestive system, it will be divided into foregut, midgut, and hindgut. And this is also in the anatomy part, we divide them as according to this blood supply. So to easy know the blood and the lymphatic drainage and the blood vessel supply or drain blood from this part, and also for the innervation. So let's discuss now this part one by one. Development of the foregut. First, what is the derivatives of the foregut? The foregut will give rise to the oral cavity, pharynx, trachea, lungs, as we discussed in the respiratory science block, stomach, proximal duodenum, part 1 and 2, and also the associated digestive organs like liver, pancreas, and gallbladder. Esophagus, the region of the foregut distal to the laryngeal diverticulum, the opening of the larynx, and proximal to the developing diaphragm becomes the esophagus. The esophagus also below the diaphragm, it will be extended for the millimeter, some millimeter or centimeter underneath the diaphragm. The wall of the upper part of the esophagus contains skeletal muscles. These skeletal muscles derived from the sixth pharyngeal arch. The sixth pharyngeal arch, if you remember, we already studied this in the respiratory science block. So what is the component of the sixth pharyngeal arch? Which cells make the sixth pharyngeal arch? يلا يا شباب. لاحظوا بنتكلم عن muscles. معايا يا شباب. Which cells, which germinal cells form the sixth pharyngeal arch? Okay, search for this question. Mesoderm, yes, but we don't call it mesoderm, not paraaxial mesoderm. Paraaxial mesoderm would give rise to the musculoskeletal. Yeah. صحيح mesoderm, but we call it mesenchyme. Mesenchyme. The pharyngeal arch, we call it mesenchyme because it's contain mesoderm and also neurocrest cells. The wall of the lower esophagus contains smooth muscle derived from the splanchnic mesoderm. The middle part of the esophagus contain both smooth and skeletal muscles. Both they are brought from the sixth pharyngeal arch and from the splanchnic mesoderm. Sometimes, as we mentioned, that occlusion process as a result of proliferation of the gut tube cells. So the recanalization process that will not complete, and the esophageal atresia and tracheoesophageal fistula may happen. So this is caused by deviation of the tracheoesophageal septums that separate between the trachea and esophagus. And this is caused esophageal atresia, and this is result in the have difficult swelling the born baby. It will have difficult swelling and fluid pass out the nose and mouth. A newborn with the tracheoesophageal fistula have severe coughing, spills while eating, the interfere with the breathing, and often pneumonia develops from the fluid breathed into the lungs. We can also take X-ray for the newborn with the tracheoesophageal fistula, and we can see the stomach is also filled with the air. بعد كده الستومك it will include dilation and rotation. Two processes, dilation and or expansion and rotation. So at the beginning, it appears as a dilation of the foregut distal to the esophagus and beneath the developing diaphragm. So here we have the diaphragm, the stomach, which will be attached anterior and posterior to the dorsal mesentery and the ventral mesentery. So the posterior region of the stomach will grow faster than the anterior region, and this leads to formation of the greater curvature of the stomach, whereas the anterior part will form the lesser curvature. The stomach, it will rotate after that around two axes, longitudinal axis and anterior posterior axis. طيب عندنا expansion, عندنا rotation, a rotation of the stomach along or around two axes, longitudinal axis from superior inferior axis and anterior posterior axis. So along longitudinal axis, the stomach will rotate 90-degree clockwise rotation. The left aspect of the stomach, it will becomes anterior. The right aspect, it will becomes posterior. So this is the stomach. It's held in place by dorsal and ventral mesentery. And you can see at the beginning, the liver in front of the stomach attached to the anterior abdominal wall. With the rotation, the stomach, it will rotate 90 degrees clockwise, and this lead to the liver, it will be displayed to the right side, and also the left vagus nerve, it will become anterior, and the left side of the stomach, it will become anterior, and the right side of the stomach, including the right vagus nerve, it will become posterior. So along the anterior posterior axis, the caudal part or the inferior part of the stomach, it will move upward and to the right side, and the cephalic end will move downward and to the left. As a result of these rotations, as we mentioned, the left vagus nerve is now in the anterior surface of the stomach, while the right vagus nerve, it will becomes on the posterior surface. The cephalic end of the stomach is to the left and to the midline, and its the distal portion, it will shift to the right of the midline. What's also you notice here, we said already that the liver, it will displace to the right side of the stomach, and also we can see here the pancreas. This is mainly the dorsal part. The pancreas, it will becomes or shift from the intraperitoneal into retroperitoneal organ. So congenital deformity associated with the development of the stomach is called pyloric stenosis. This is result from the hypertrophy or increase the size of the pyloric muscles part, and this is result in gastric outlet obstruction. And the symptoms include the infant, it will expel the stomach content with the considerable force. And here we can see this is the pylorus part is hypertrophy, and here's the accumulation of the stomach contents. The duodenum develops from the two sources, as we mentioned, the upper half from the foregut, the lower half from the midgut. It grows rapidly and forms the C shape. So the C shape of the stomach is a result from the rapid growth of the duodenum. So when the stomach rotates to the left, the duodenal loop is displayed to the right. So when the stomach rotates along the anterior posterior axis to the left side, the duodenal loop will displace to the right side. As a result of these rotations, the biliary opening, it will carry from the ventral aspect to the left side of the duodenum. The mesentery crosses the duodenum and fuse with it, and giving the duodenum, mainly the upper part, the retroperitoneal location. After that, developing of the midgut, we said the midgut, it's supplied by the superior mesenteric artery. The midgut deferentives, it will give rise to the duodenum, the lower half of the duodenum, or part 3 and 4, and the jejunum and ileum, cecum and appendix, ascending colon, and the proximal 2/3 of transverse colon. The mid-gut development will include increase the length of the mid-gut, and as a result of the decreased space of the abdominal cavity, as a result of the enlargement of the liver and kidney, the mid-gut will undergo physiological herniation. That the mid-gut will go outside or extend to the yolk sac and then back. So this extension or herniation into the umbilical cord, and this is between week 6 and week 11, and this is include a counterclockwise rotation, 270 degrees. So it will form a loop, intestinal loop, and this intestinal loop can be divided into two parts. This is the intestinal loop, the mid-gut. So here we have the duodenum, intestinal loop, and here we have the distal part of the transverse column. So the intestinal loop, we can divide it into two parts. We have the proximal limb and the distal limb. The proximal limb extends from the duodenum or the lower half of the duodenum to the vitelline duct, and this part will give rise to the distal duodenum, jejunum, and the proximal ileum. And the distal limb, it will extend from the vitelline duct up to the proximal 2/3 of the transverse column. And this part will give rise to the distal part of the ileum, cecum, appendix, ascending colon, proximal 2/3 of the transverse column. So the intestinal loop, it will rotate during the herniation. It will rotate 270 degrees counterclockwise. We can divide this rotation into two parts, herniation and retain. During a herniation, it will rotate 90 degrees counterclockwise around an axis formed by the superior mesenteric artery and vitelline duct. So the axis of this rotation, it will be the superior mesenteric vein. And then it will return. So when it returns, it will return about the week 10, and the size of the liver and the kidney has decreased in relation to the size of the abdominal cavity. So it's returned with the 180-degree counterclockwise rotation. By the time the intestine retain and the vitelline duct is normally obliterated and lose its connection with the intestine. Remember, this is the rotation, the final shape of a rotation or of the mid-gut. You can see here we have the appendix, cecum, ascending colon, and the proximal 2/3 of the transverse colon. The place of the vitelline duct, usually it will become at the distal part of the ileum, at this part, at the distal part of the ileum. So anomaly associated with the development of the mid-gut, we have the Meckel's diverticulum. This is incomplete obliteration of the vitelline duct and remains attached to the anterior abdominal wall or the another nervy structures, and usually can be found in the distal part of the ileum. We have the furfurus, is a twisting of the lobe of intestine around itself. This is affecting its own blood supply and result in the ischemic death for the tissue of the mid-gut. We have the omphalocele. This is a defect in the anterior abdominal wall. The herniated mid-gut, which will remain outside of the abdominal cavity, and the complication associated with this anomaly, including infection, rupture, and intestinal obstruction. We have also male rotation, so the sequences of rotation sometimes does not occur as we expected. So this is the result when the normal sequence rotation is interrupted, and it's a result in the midgut fibrillus also. And we have different male rotation shapes. We have non-rotation, so the small and large intestine, they will align to each other. So the small intestine will be in the right side, and the large intestine it will be in the right side. We have reserved rotations, so the duodenum it will become superior to the transverse colon. And also we have subhepatic cecum. The cecum it will be up here in different position below the liver. So this space will include only the small intestine. Then we have the development of the hindgut. We said the hindgut supplied by the inferior mesenteric artery, and the hindgut which will involve the deferentives, including the distal 1/3 of the transverse colon, descending colon, sigmoid colon, rectum, and the upper portion of the anal canal. So the development of the anal canal, the upper 2/3 derived from the endoderm of the hindgut, and the lower third it will be derived from the ectoderm lining the external surface. The mesoderm septum, urorectal septum, will be divided the cloaca into two parts, as we discussed in the genitourinary block, into urogenital sinuses and the rectum and anus. The cloacal membrane also, it will be divided into urogenital membrane and anal membrane. We have one anomaly associated with the development of the hindgut is the Hirschsprung's disease. This causes dilation in of the colon as a result of the accumulation of the content of the colon, and it's not move out or toward the outside of the body. And this is a result from the failure of the neurocrystals to migrate to the wall of the colon. So there is no peristalsis function that help to move the content of the colon forward. We have the imperforate anus, no anus, or the absence of the anus, resulting from the abnormal development of the urorectal septum and result in complete separation incomplete separation of the cloaca. We have different type of the absence of the anus. We have the persistence anal membrane, and we have the anal atresia. We have the anopreneal fistula, and we have the rectovaginal fistula between rectum and vagina, and we have the rectourethral fistula between the rectum and urethra, and we have the rectovesical fistula between the rectum and the urinary bladder. And then associated organs development. First, the liver. The liver develops from the endodermal diverticulum. So the germinal cells that give rise to the liver is the endoderm cells. It forms the hepatic diverticulum and the ventral mesentery, and it will grow to the septum transversum that will give rise to the diaphragm. The endodermal cells of the hepatic diverticulum, it will form cords of the hepatocyte cells and the bile caniculi. And during 5th to 24th week of development, the liver will work as the hemostasis site of the body that provide the blood cells to the body. And then the bile duct system, it's also the bile duct is formed by the hepatic diverticulum from the endoderm cells and will give rise to the interhepatic bile ducts inside the liver, and also the hepatic ducts, the cystic ducts, the gallbladder, and the main pancreatic duct, the main or the common bile duct. And then pancreas, formed by two endodermal derived buds. The dorsal posterior pancreatic gut is an epigenation of the foregut, grow into the dorsal mesentery, and the derivatives include the accessory pancreatic duct and superior portion of the head of pancreas and the body and tail of the pancreas. The ventral part is an epigenation from the hepatic diverticulum. So all the common bile duct diverticulum include liver, gallbladder, the ventral pancreatic ducts. This comes from what we call the hepatic diverticulum. To grow into the ventral mesentery, the ventral part, which will include or affected by the foregut rotation, and it will join the dorsal pancreatic buds to form the pancreas. So the adult derivatives of the ventral part, which will be include the main pancreatic duct, incinate process, and also the inferior portion of the head of the pancreas. Remember that the dorsal pancreatic duct will not affected by the foregut rotation. The dorsal pancreatic duct will not affected by the foregut rotation. Only the pancreatic main bile duct derivatives, including the bile or the opening of the ducts, and also the ventral pancreatic bud. The pancreatic cells, islets of Langerhans, are endodermally derived, whereas the connective tissue and associated smooth muscles are derived from splanchnic mesoderm. Then we have the spleen. The spleen develops from the mesodermal cells between the layers of the mesogastrium of the dorsal mesentery, and the mesogastrium differentiate into linorenal ligament between the spleen and the kidney, left kidney, and the gastrorenal ligament between the stomach and spleen. This is video, you can watch it later for the development of the gastrointestinal tract. Any questions? So let's go through these questions. Or before we go to these questions, there are some videos we can see it together. Application screens. Yes. واضحة الصورة عندكم يا شباب؟ على السكرين.
نعم.
First video regard the cephalic and caudal folding. Here in this picture, we can see the lateral folding that help to form the midgut. However, the cephalic and the caudal folding, we can see it here, that help to forming the foregut and the hindgut. So here we can see this is the cephalic folding, and here we have the caudal folding. To the process of the proliferation and closing the gut tube. After that, week 8 to 10, we will start the apoptosis process for recanalization of the gut tube. Here for the dilation or expansion of the stomach and rotation. At the beginning, it will be expanding, and then it will rotate. Okay, let's see it now again. So this includes expanding and sorry, and also rotate through the anterior posterior to shift into the left side. Here you can see the developing of the midgut and the hyalination process, the hyalination of the midgut to the yolk sac. So here we can see this is the liver. You can see the size of the liver and kidney, and here we have a small lung. Okay, for that, this is the abdominal cavity. So we have a small abdominal cavity, and this lead to push the midgut to urination or to urinate outside of the body to extend and then back. So this is the mesentery, and this is, you can see, this is the midgut. This is the midgut during the urination. Here we can see infant with the homophysaly that that affects, or the urinated midgut, which will be sustained or outside of the body. You can see it here now. So this is the infant, and we can see this is the midgut urinations. Or intestine, it will be kept outside of the body. Okay. Here for the development of the anal canal and development of the mesodermal septum of the urorectal septum that divided the cloacal membrane into two sinuses, urogenital sinuses and the rectum sinuses, and dividing also the cloacal membrane into also urogenital membrane and the anus. Again. So the urorectal septum, it will be extended to divide the cloacal membrane into two sinuses. Here for the peristalsis function, also we'll discuss this inshallah in the histology of the small and large intestine. This is the peristalsis function that help to move the colon contents forward. كان هذا الفيديو الأخير. Question. شباب من حابب يشارك الفيرست question؟ Yes, عبد الرحمن.
يس دكتور، السلام عليكم.
Yes. عليكم السلام ورحمة، حياك الله عبد الرحمن، تفضل.
الله يحييك دكتور. First question says the mind gut begins with space and ends with, I believe the right answer is D, half the duodenum, so parts 3 and 4, and
Yes.
2/3 of the transverse colon.
Yes, correct. The midgut begins with the half of the duodenum and end with the third transverse colon. It will be the lower half. Should be
Yes.
the lower half, or the common bile duct, and the end with the 2/3 transverse colon. شكرا عبد الرحمن. Second question. Second questions. عبد الملك العنيزي تفضل. عبد الملك. سواء عبد الملك العنزي. تفضل عبد الملك. So the middle of the duodenum would receive blood from both the celiac and the superior mesenteric artery. ممتاز عبد الملك. طيب. The question: the first stomach rotation caused the and vagus nerve to become the space and space vagal trunks respectively. Answer it will be ليت يا شباب نستخدم المايك. طيب ايه صحيح. left right vagus nerve to become the anterior and posterior. طيب question number 4. Question 4. Stomach rotation caused the duodenum to take on a shape. During the second month, the duodenal lumen closed but is recanalized by which process? صحيح يا عساف. صحيح. It will take C shape and will be recanalized by the apoptosis. صحيح. What two structures only form on the ventral side of the bile duct? The ventral side of the bile duct. صحيح. محمد الفريح مطيري. صحيح. It will be the liver and gall bladder. The liver and gall bladder. Remember, the bile duct fertives قلنا يكون عندنا الليفر، يكون عندنا الجول بلادر، يكون عندنا اللي هو الفنترال باتس اوف فنترال بنكرياتيك بات، يكون عندنا الكومن bile duct. Only the ventral pancreatic bud and the common bile duct it will be affected by the foregut rotation. طيب, which of the following is not part of developing pancreas? Which of the following is not part of the developing pancreas? It will be C. صحيح يا العواد صحيح. Ventral bile duct. Which of the following is not part of the developing pancreas? Ventral bile duct. Meckel's diverticulum is a congenital connection from the umbilicals via vitelline ligament to the which part العادة؟ اللي هو الإيليوم وتحديدا the distal end of the ileum, the distal part of the ileum. طيب. During week 6, the midgut herniates through the umbilical ring, rotating degree counterclockwise. Near week 10, the midgut return, rotating degrees, and the total will be D. صحيح. 90, 100, 180 when it's returned. So 90 herniation and return with the 180, and it will be the total 270. طيب السؤال الأخير أتوقع a 3-week-old male infant comes into the emergency room for weight loss and acute dehydration. The infant has been projectile vomiting and the condition is worsening. While which of the following is most likely? Will be B. Pyloric stenosis. And this is the answer. أحسنتم يا شباب. أحسنتم.